Thank you very much, and thanks, Shubham, for that interesting presentation. You know, I was struck in your slides. You had the key insight, I think, is that the more insurers that you have, the more there's price reductions or price competition. And, you know, one of the things you hear a lot from academic health economists is that that's not true. That if you have more insurers, prices will actually go up, because if there's more insurers competing, then the hospitals have the leverage over the insurers. But if you have less insurers, like in a single payer system, then the insurers have the leverage over the hospitals. So what are your thoughts on that?
Yeah, I mean, I think it's an interesting question. So what we have seen is that there is a correlation that exists between markets where there is more competition on these exchanges and or markets where new entrants have entered, that we're seeing prices being different. Now, the hard part in that is, and we haven't quite completed the analysis because there's regional variations of cost structures. Also, the markets where you see that are also more competitive markets from a provider standpoint as well. And so there's some amount of it that we've got to tease out what the correlation is versus causality in that. But at least the threat, if you will, of competition seems to have prompted innovation around networks, as we've clearly seen, and people using different kinds of network designs and managed care products to bring the cost down.
And the variation that you're seeing in the number of plans in a particular state, is that historical accident, or what's driving? Are there regulatory or is the government driving some of those diversities or conformities in the number of plans that you see in particular states?
Yeah, it's an interesting question. We certainly haven't studied the correlation with government policy on this. Some of this is that there are larger states that have actually taken a pretty active part in shaping what the carrier responses would be. Now, carriers are also rational in figuring out which the more attractive markets are, where the growth is the most significant and the opportunity exists. So I think that's a bit of how we've sort of seen it play out. It's hard to see, other than a bit by size, frankly, if you take 16 carriers in New York, which is the highest, California. Clearly, big states have attracted more attention. Now, there's a lot of variation within a state as well. So urban areas have attracted as well more players really kind of focusing in those when we get to a rating area level below, underneath a state.
Great. That's very helpful. Thanks a lot, Shubham, for this presentation. So now we're going to welcome Robert Robbins and Ron Williams to the stage to join us to have a discussion about Obamacare and the Affordable Care Act and where we stand today with the Affordable Care Act. So please join us if you're back there. Welcome to Ron Williams. Thank you very much.
It's a pleasure.
And Robert Robbins, who is the CEO of the Texas Medical Center, is on his way, I hope. Back there somewhere. Well, while he's getting on the stage, since we all have you here, maybe Ron, what are you seeing in terms of? I mean, you were the CEO of Aetna, and you are now obviously watching all this from the envious perch of someone who has some time on his hands, perhaps, but is keeping himself busy. What are you seeing in terms of how your colleagues are getting involved in these exchanges that have launched this past week?
Well, I think I'm fortunate in my current role that I get to see the system from various perspectives. One of the things I'm involved with is a company called Envision Health, which has 28,000 clinicians who actually work in hospitals. They're physicians, ER doctors, intensivists, and then my work with Johnson & Johnson gives me a sense of what it looks like from pharmaceutical, medical devices, and broadly speaking, consumer health. I think one of the things that is important is that the ACA really represents a major inflection point, giving the industry permission, broadly speaking, to transform itself. I think the legislation itself, which focuses primarily on accessibility with some hints here and there about quality and IT and others, but fundamentally what we have for the first time is a broad-based discussion about how we transform the system to create more value and more health.
And Dr. Robbins, I mean, you run one of the largest medical centers, one of the most important medical centers in the country. One of the things that, and I know that you and I have talked about before, we hear, and we heard from Shubham's talk earlier, that what a lot of the plans are doing to try to reduce costs is narrow the networks, the hospitals and doctors that they put in these plans, and usually that means the high-priced academic medical centers like the ones you represent are getting excluded. To what degree is that happening in Texas, and to your knowledge?
Well, I think it's too early to tell exactly what's going to happen. You know, we're really early into the process, but I think there's clearly going to be a change in the way that even the big academic medical centers are going to respond. And it's primarily going to be to change from the large high-volume fee-for-service to a more managed approach. But at the end of the day, I think that the thing that's going to happen is we're going to see a shift toward more transparency in requiring all practitioners, even the surgeons who do high-volume, complex cases that have made a lot of money off of doing many cases that are complex because they were rewarded for it. And remember, doctors do what you pay them to do, right? So I think it's going to focus and drive incentives towards higher quality at lower cost, without question.
Interesting. So, you know, one of the things that you know, we've heard about in the last week or two, that there was all this stuff in the headlines about the glitches with the websites on the exchanges. Do either of you, Ron or Shubham, do you have any insights into from the IT architecture standpoint into what's been going on with the exchanges and how quickly that will get fixed so that people can actually enroll in the exchanges?
You know, I don't have any specific insights. I think people have been pretty radio silent on the specifics, people I've talked to. I think broadly speaking, this is noise in the system. It clearly, if the new programs are a brand, the brand is starting off a bit tarnished by virtue of poor execution. I think fundamentally long term, it's noise that will disappear over time, and we'll get down to the basics of how the programs operate and what kind of value they really bring to the uninsured.
And I should mention that we were supposed to have Kevin COUNIHAN, the CEO of the Connecticut Exchange here, who was going to share with us some of the details, the early details of enrollment in the Connecticut Exchange, but unfortunately his wife had to undergo emergency surgery last night, and so he had to fly back to Boston. So he sends his regrets, and we obviously wish him well. Shubham, one of the things that you talked about in your slides earlier was there were two basic ways in which insurers are trying to bring costs down. One was the narrow networks that we've talked about. The other was through the risk adjustment program. And maybe for people who aren't familiar with what risk adjustment is and how that component of health insurance works, maybe you can explain what that's all about.
Yep. So a couple of things within that. One is the Affordable Care Act does provide a reinsurance scheme which essentially allows you, for the very catastrophic cases, there is funded money from the government that gets paid. So that brings down the cost, if you will, of the risk pool. It is transitional over the next 3 years. And so it's not a forever program, but nonetheless, at least in this point in time where we're likely to have some turbulence, it brings the pricing down. The other one is around risk adjustments. Essentially, in a world where we're not underwriting and we're not rating for health risk, it is a program that essentially balances out the profitability, if you will, or lack thereof, between healthy and less healthy people in terms of their claims. And so what it basically does is it's a zero-sum program that transfers money. And the simple way to think about it is a person that's healthy and has no claims, that gets applied, if you will, across the risk pool to those that are higher risk, higher claimants in the system. And what that does is it kind of evens out the profitability. In fact, you know, if you do the modeling, what it shows is some of the folks with some of the higher conditions may actually be more profitable when risk adjustment works its way through than the absolute healthy.
And Dr. Robbins, you know, one of the things that we've neglected, we've been talking a lot about the exchanges because they launched on October 1st, but it's important to note that of the 30 million people who are supposed to get health coverage through the Affordable Care Act, half of them are through the exchanges, give or take, and half of them are through the Medicaid program. Now in Texas, Texas has elected so far not to expand the Medicaid program. What are your thoughts about that? How do you see that affecting the economics of your medical center?
Well, I think in Houston, because the Texas Medical Center is so large, there are 54 institutions that make up the medical center, over 100,000 employees. I think that there are many different systems, and the issue is going to be the balance between those institutions. For instance, if you look at the payer mix for the different institutions, some of the institutions are bearing more of the burden of the Medicaid population and the uncompensated care. So without expansion of Medicaid, those are the institutions that are going to be affected more dramatically. The good news is that there's a robust county system that's funded, but obviously inadequate to handle all the patients. I think there will be a shift, though, once people get coverage. The hope is, it's not a guarantee, obviously, but the hope is that because they get coverage, they're going to go to their doctors and do some preventative care, rather than the way that most of the people in the Texas Medical Center at least handle their care when they're not insured is coming to emergency rooms. So we're overburdened, particularly at the Ben Taub Hospital and Memorial Hermann Hospital. Is the largest and busiest trauma center in the country, and oftentimes it's backed up by people using it as an outpatient clinic. So I think there are going to be issues in terms of what happens to the money in terms of uncompensated care that's taking care of those patients today. Because if you take that away and Medicaid's not expanded, which Governor Perry has made it very clear he's not going to expand Medicaid, then we're going to have to look for alternative ways to maintain the funding for uncompensated care. Otherwise, the costs are going to be delivered to people who do have insurance.
In your emergency rooms, is it the uncompensated or the uninsured population that's going to the emergency room? Because a lot of times what you see is it's actually Medicaid patients who can't get access to a primary care physician or regular care. They're the ones who are showing up in the emergency room. And in fact, in Massachusetts, emergency department volume increased after a reform in 2006.
Well, certainly that's been one of the concerns, is that the patients would continue to do what they had always done, because it's a cultural pattern almost that you get your care at the emergency room if you grow up in a particular culture. I think that right now so many of the patients in Houston at least will bypass, and this is another problem, and it's a cultural thing that has to be changed. They will bypass many very good local federally qualified health clinics to go down to the medical center to get what they think are the best doctors and the best care, because they have a Baylor codon or a UT codon. Now, as we all know, that many of the times they are seeing interns or residents right out of medical school when they should be staying in their community. So I think there's going to be a lot of focus on education and cultural change, at least in the Houston community. And that's one of the primary objectives of the medical center, is to focus on what's one of the largest uninsured populations of any major city in the country, almost 30%. It's one of the most diverse cities in the country, and I think that there are pockets, and one solution is not going to fit all. Different cultures and different communities have different norms, and we're going to have to work hard to change their behavior.
Ron, one of the things, and maybe Shubham can pipe in as well on this, one of the things that has come out in the news the last couple of weeks is interest of large companies in shifting their workers to private exchange. So instead of just offering their workers a plan, they're working with outside firms to set up these private exchanges where you give a defined contribution of several $1,000s and let the workers choose the plans. And that's also attractive to the carriers, to the insurers, because it's a higher margin product in some ways compared to some of the other things, some of the other trends that are out there. What are you seeing in that regard, and what are your thoughts about that?
Well, I think it is a trend that we're going to see grow. I've talked with a lot of CEOs from different sectors, and companies are evaluating it. It's attractive for several reasons. One is consistent with giving consumers more choice, so that the employee is able to have more optionality in terms of the type of plan. The other thing is that once the company sets the contribution, which quite often is set at the same or even a slightly higher contribution than they make today, the employee begins to view those dollars as their own and begins to make different choices. And many people, in fact, are overinsured. And so what many people are seeing is that consumers are trading down and still having very good substantial coverage because the company is putting curbs around the options that the employees can pick. So I think it's a trend we will see continue to unfold, and I think we're likely to see more innovations on the private side that will move pretty rapidly.
Shubham, you have any thoughts on that?
Yeah, we certainly see that continuing for the reasons Ron stated, and one of the interesting things that we see happening is while there are a number of people, particularly the healthier, who will buy down the medical benefit from being a much richer benefit, we also see diversity of choices being made, which I think in general is a good thing for consumers. And we also see them actually spending money above contribution limits. There are a reasonable number of people doing that in these private exchanges, and they are buying additional coverages that they need, whether it's life, it's disability, it's dental, it's vision. So some amount of the supplemental coverages that, again, depending on the life stage of the particular employee and their family could be quite relevant. We actually see them doing that. So if you look at that, it kind of suggests that people are finding a better mix of the coverages that they need through these exchanges. The only other thing I'd state is we've tested this with consumers where essentially in a private exchange simulation where we asked them the interest in it before and interest after going through the purchasing experience. And the interest went up about by a third after they had been through it in having been able to make those informed decisions.
So they're much more engaged after having had the chance to shop.
Yes.
And one of the things that we've seen a huge growth of in the last 10 years has been health savings accounts combined with more high deductible coverage. How do you see the Affordable Care Act affecting that trend, given that it regulates the kinds of products that can be sold?
I think it adds more regulation, but I think if we look at a bronze product or even a silver, it allows for fairly meaningful deductibles other than people who will get the cost-sharing subsidy. So I think that plays out. What remains to be seen, a lot of the innovation that we've seen happening as the exchanges open is around network. What remains to be seen is what further innovation do we see around various kinds of plan and incentive design using the cost sharing, because I think we've now, in about a decade of playing just the deductible part of it, the question now is do we get more intelligent designs that actually start moving behavior in different ways?
Ron, what kind of intelligent designs would that?
Well, I just want to comment a little bit on the HSA. I think one of the potential risks is continuing regulation or over-regulation of the self-insured market, because I think many of the innovations that I've seen unfold in the past 10 years or so have come out of the large self-insured employers who have very substantial populations.
Stop and explain what self-insurance is for people.
Self-insurance is a situation where instead of the company paying the health plan a premium, and the health plan is responsible for whatever claims are incurred, the company assumes the claim responsibility and pays the health plan for a package of services. The company then evaluates those services very carefully and often looks at boutique vendors, new innovations, and has a plan package those in to the administration of its plan. And I've seen an enormous amount of the innovation come out of self-insured employers who often have their own medical directors who really look for ways to do things like the whole disease management development that we've seen, centers of excellence where people go to places where they really have very extensive expertise in solid organ transplant and others. So I think one of the risk is that we dampen down the innovation that we've seen from the self-insured by layering more regulation on self-insured employers.
And Robert, one of the things you hear from skeptics of health savings accounts is that, well, you're not going to shop when you get hit in the head or you get shot or you have a heart attack. So to what degree in the hospital setting or in some of the things that deal with, do you see the consumerist impulse affecting, or does it not affect it at all? I mean, how does HSAs and how does the consumerist impulse affect the big medical centers like yours?
Well, I don't think we've seen much of an effect to date. But as Mr. Forbes was outlining, I think that the world is changing, that the patients are being empowered, given more tools to make better choices. But that's going to be another cultural shift that patients have to assume some responsibility for their own disease process. And to date, it's almost like going to class and having the professor teach you everything you need to know, but you don't do any of your homework. You know, the health actually, I think someone commented last night, health actually goes on between doctor visits. So patients are going to have to assume some responsibility for their own health. Currently, there's no real incentive to force people to do that. So I think that the decisions that are made, and to get back to your question, is that I don't think we've seen, at least in the Texas Medical Center, we haven't seen health savings accounts really affect much of what we're doing.
Before we get to questions, and I'll get to questions, ask you all to think about questions while I ask this last round for the panel. It's called the Affordable Care Act, and we talk all the time in the health policy world about costs. Healthcare is too expensive. The U.S. spends too much compared to other countries, not just in terms of private spending, but also public spending. Government, it's not widely understood that government spending on healthcare in America is actually, on a per capita basis, much larger than it is in most other countries in the world. And there's been this slowdown, this trend in recent years for costs to come down a little bit, or the growth in costs has not grown at the same rate as before. Do you see, Robert, the Affordable Care Act having a big impact on costs in either direction?
I think it will. I think, it's too early to tell again, but I think it will, because if nothing else, the perception of hospitals, physicians, 70% now of all physicians in the United States are employed. That's a large number, and it is probably going to 100% in the next 10 years. So decisions are being made at the system level.
And by employed, you mean that they're not in private practice,
Correct.
They're being employed by hospitals?
They're either employed by a system, a hospital, an academic center. My point is that a lot of what's going to happen in terms of delivery, focusing on quality, focusing on cost, is going to be top down. They're going to be held accountable for their outcomes, how much money they spend per patient, and that's going to be first done, I believe, with surgeons, because it's easier to measure those things and to control them. But I do think that this curve is shifting, and there will be positive effects on the cost side, and I believe that quality is going to increase, because there's going to be more public reporting, more transparency, and you're basically going to be paid for performance on your outcomes. So yes, I do think there's going to be a positive impact on cost.
Great. Ron, pessimist?
Yeah, just a couple of quick comments. I think that when we approach what we spend on health care, we spend an enormous amount, $2.7 trillion, and I was trying to figure out a way to really grasp how big that number is, and it is equal to the gross domestic product of the country of France. And, we know it's a big number, but when you think about it as that big and you say, tackling that, restructuring it, redesigning is a pretty huge, enormous undertaking. I think that the act is a contributory effect. I think also that the recessionary economy put a lot more steel in the backbone of the CEOs in America, who began to examine the cost structure of benefits and began to really ask more of their employees in terms of beginning to explain things like the metabolic syndrome, creating incentives, creating wellness programs, beginning to start focusing on prevention. So I think the Affordable Care Act is a contributor. I think the recessionary economy is a contributor. And I think the permission to begin to transform the system from pay for performance to really outcomes and accountability. For the average consumer about transparency, if it's a non-life-threatening issue, generic drug versus brand drug, transparency and pricing data is very helpful.
Yeah.
When it becomes a serious health issue, transparency is about quality. Mm-hmm. And I think we're going to see transparency in those two contexts have a very important contributory effect as well.
Shubham, your thoughts?
I think the point that I look at it is if we set the legislation itself aside, what has happened right now is it has sparked a bunch of innovation. People are it's unstuck the industry in to basically try a lot of new things, whether it's on the provider side, whether it's payers and carriers, whether it's others. And that has the opportunity to basically unleash what are some of the secular forces a bit independent of the legislation. So technology and all that it enables, the changing structure where we're able to, with data and data-driven management, able to bring together larger systems of care and so on, and even enable the kinds of payment models we're talking about, which would have been quite hard to do earlier, as well as enable the kind of transparency to engage a consumer in any meaningful way. Not that all of that has happened, but I think what it is allowing is a number of underlying secular forces that can now be unleashed to actually drive the innovation to a next level. So I think that's what it more is rather than the actual argument over the particular legislation at hand.
Great. So
I would agree with that. I think there's tremendous opportunities in the amount of waste that's in the system, but technological and systems approach, innovative technological and systems approaches to improve patient flow, whether it be Six Sigma or Lean or whatever. There are a lot of things that I think are going to evolve, and they're going to be a void that's going to be filled by entrepreneurs. I saw something last night, one of the companies about hand washing. I mean, that seems so fundamental in most hospitals, but if you really are able to get the data and measure it, you would be appalled at how few people wash their hands in hospital. And as you go down the line to the CMS never events, and remember, the private insurers are going to follow the lead of CMS.
Centers for Medicare and Medicaid Services, for those
Medicare. Then these never events, many of them are related to infection. Just the technology of being able to track whether someone washes their hand. It was a simple system. I liked it, and it gives more data for us to measure and change the behavior of doctors and nurses and people who touch patients.
Great. So let's get some questions in. Are there anyone with questions? We got some mics circulating, and if you have your hand, raise your hand up. We'll get a mic to you, and please state your name and your affiliation, and please be brief.
Thanks. I'm Robert Waugh. I'm the Chief Medical Officer at Computer Sciences Corporation, CSC. And I guess I just want to go back to where you started with the exchanges. We're here in New York, and I just want to point out that New York has one of the independent exchanges. I think you pointed it out. There's been a variation in success about access to it. And I was going to bring that up as well. I think Donna Frescatore, our client here in New York, said that they've registered 40,000 people on their website, which is pretty good in the first week. There's a fair variation across the country. Some states have had less success than the federal one. But my question is, what do you all think about the ability of patients that are coming to these new exchanges to understand the complexity of getting new insurance? Because there are oftentimes people who have not traditionally had insurance before, and so they're sort of new to the insurance marketplace. And the question would be, how sophisticated will they be in shopping for insurance on these exchanges? Oftentimes it looks like they're price sensitive only, and they don't recognize sort of the fine print of what is in the policy, what's covered, what's not covered, what's their copay. So I'd be interested to hear what your thoughts are on how is this new cohort of patients coming into the exchanges going to be able to navigate what has traditionally been a fairly sophisticated process to acquire insurance.
Who wants to take that?
Yeah, I think that's a huge issue. And oftentimes the more options you have, the more frozen you are in trying to make a decision, even if you do understand the process. This is a major problem, and it's something that I think, at least in the Texas Medical Center, we're trying to provide services to help inform and be a resource center. And I think many of the states and the municipalities are trying to do the same in terms of educating people so that they can make better choices. But you're right, this is a major issue, and I think we'll just have to wait and measure the data and see how that affects things. But they're going to be unsophisticated.
Yeah, I think that the experience is pretty clear that when consumers are often purchasing, they're thinking about purchasing from the context of being a non-user of the healthcare system, unless they already have some kind of ongoing healthcare event. Individual insurance in particular, historically, it was sold, it wasn't bought. People just didn't pick up the phone and call. Somebody sat them down and took them through all the details and intricacies. And I think the health plans are going to have programs to try to explain, increase the literacy, increase the understanding. It will clearly be a process. People will make bad choices. That's what we all do in our lives as consumers. Fortunately, they get a chance to correct that on an ongoing basis. But there is an enormous amount of just fundamental insurance literacy, let alone health literacy, that we need to focus on.
Yeah, I mean, I think the simple matter of fact, I think, is that the unaided purchase just in the exchange is small. I mean, we saw this in Massachusetts. We're seeing this with the call volumes that are spiking, whether it's in navigators or insurers or others. And so most of the folks are going through some kind of an aided process one way or the other in actually talking to someone and understanding their options. It's also evident in the calls that are being handled now are 4 to 5 times as long as they would have been in the previous individual market, which is clearly people trying to have a lot of questions and want to understand. So, part of it will work because there are a lot of resources out there from insurers interested in selling, but also others like navigators and the like interested in educating people. And that's kind of going to be an important part for a while to come till people actually fully get literate, I think, as Ron said.
Okay, next question. Up there.
Yeah, I didn't hear too much about clinical research. I'm Larry Norton, Memorial Sloan Kettering. And we're talking about delivery of healthcare as we currently understand it. In areas like cancer, it's not adequate. Obviously, we have to do better. How are we going to afford clinical trials in this new era?
Dr. Robbins?
Yeah, I think that's a major issue. And not just clinical research, I think fundamental research. With the decrease in funding from NIH, many, as you well know, most hospitals, the way that they work is there is a payer mix, so-called payer mix, where there's a commercial component, there's a Medicare component, and then there's a Medicaid or an insured component. And oftentimes, at least in the academic medical centers, there's the so-called funds flow of money from margin from the hospital over to help support the research. Because to be clear about it, research is a cost center. It's not a profit center, as is education. So that money has to come from somewhere, and traditionally it's come from the hospitals. And those of you who are in the academic medical center business know this. My concern is that there's going to be not only a decrease in the money to do clinical research, but also the fundamental and basic research. And oftentimes the clinical research is done by sponsors, commercial sponsors, but as you well know, most of the time the hospitals will fund investigator-driven single-center research, and I think the same thing is going to happen. We're going to cut into the margin, and that's a big concern that I have in terms of holding our position as the leader in discovering the life sciences. A lot of it has to come from the clinical side and is oftentimes funded by hospitals. We get a bad deal on the amount of money we spend for the quality outcomes that we get in this country compared to other countries. And if we start cutting in to the margin on the hospitals, then I think the research side is going to suffer without question.
Shubham, McKinsey deals with a lot of the major pharma and biotech companies. Do you have any thoughts on how R&D spending is going on that side of things?
I think I wouldn't comment too much on it, but I think it's well kind of understood that there's also a productivity challenge with much of the research right now, and so that is another part of the challenge that we kind of deal with as we reorient the system, because clearly there are promising technologies in development. We just kind of have to figure out the funding model, which is clearly under strain from a number of different areas, and I'm not quite sure that there is an answer that is evident at this point.
Yeah, I think we're going to hear more about that later in one of the other panels but it's clear that even though I'm not in the pharmaceutical business, it's clear that the resources that are being dedicated there for research and development are decreased compared to what they were 10 or 20 years ago.
Okay, next question, maybe on this side, over there, okay.
Thank you very much. a question that I would like...
State your name and your
Louis Kanda. I'm a cardiac surgeon, retired, and part of the Dikembe Mutombo Foundation. A question on cost. We're dealing with healthcare delivery, and then you're dealing with the other determining factor in terms of cost, i.e. individual behaviors, environment, genetic predisposition. Which one is more costly? Which one is responsible for higher cost? And I suspect the other determinants are. And if that's the case, how are we addressing those other determinants? Delivery is easy to deal with, but how about the other ones?
Who wants to take that?
Well, I think we're beginning to have the conversation, and I think obesity in America is just one of the examples that would be quite reflective of the question you're asking. And I think we're in the throes of the debate about to what extent is it the role of society, the role of government, the role of the individual, where is individual responsibility, and we're beginning to see, broadly speaking, some actions in that direction. And the analogy, and it's an imperfect analogy, but it's the social marketing phenomena we saw around things like seatbelts, smoking cessation, drinking and driving. It's creating a new set of norms that where wellness, fitness, engaging in healthy behavior becomes something that is the new norm. Now, we got a long way to go here in the U.S. on that, but I think that would be one example. I think I would say that the sun is kind of just barely coming up, but the trajectory is the right trajectory from where I sit.
Yeah, I would agree with that. I love those examples about, I can remember actively taking the seat belts out of my hot rod when I was a teenager. My sons would never think of driving a car without a seat belt, drinking and driving, smoking, things like that. There's no question about it. But I think to the question about cost, oftentimes, though, so much of it is the individual surgeon making choices, using tests, getting an echo before discharging every one of their patients, keeping their patients on the ventilator longer. More and more of that is going to be changing, no question about it. But I do think the issue about operating on older, sicker patients, and we don't have time to get into all these things, but I think as cardiac surgeons, what's going to happen is if you're getting paid in their pejorative measures that disincentivize you from taking on those tough cases, there's going to be de facto rationing. You're not going to operate on that 85-year-old frail person with COPD, diabetes, hypertension, renal failure, as we've done before.
Yeah. All right, next question. Sure.
Good morning. I'm Kim Rice from Washington, D.C. Innovation Care. And I had a question about the new influx of patients that will get the Medicaid products and the managed Medicaid products, but will go to providers and centers that aren't contracted with these companies. Therefore, they'll be, shifted in the direction where they can get the care, but the reimbursement rates are much too low.
That's an issue. So Medicaid, as you all know, but maybe not everyone in the audience knows, pays doctors and hospitals a lot less to care for patients than private insurers do, and that has led to a lot of problems for access, where a lot of physicians don't take Medicaid, and a lot of hospitals try to shunt those patients away. Who wants to take that? Maybe, Robert, you want to take a shot at that?
Yeah, I think that's a major issue. Again, going back to the payer mix, the way hospitals make their money, they hope to break even on Medicare reimbursement. They know they're going to lose money on Medicaid and obviously the uncompensated care, but they're trying to make their margin off of the commercial entity, and this is a major problem. There was the University Healthcare Consortium did an exercise, a retreat, where they took a typical kind of academic medical center that has sort of a combined budget of $2 billion between the School of Medicine and the hospital, and they forwarded the proposition that over the next 4 years, your payer mix is going to go to a single payer system, and it'll be at CMS rates. How are you going to make the system work? You know, it's just like our national debt. You can either grow your way out of it, you can tax your way out of it, or you can save your way or cut your way out. And so hospitals are going to be faced with this very question because the rates are going to come down, the insurance companies are going to lower their rates, and there's no longer going to be that margin.
Shubham, you know, one of the things that we've seen in the past is, as Robert was mentioning, hospitals will raise prices for commercial insurers to compensate for the fact that the government payers are paying less and less. Can that continue in the post-ACA world?
I think the short answer is no, because, and I think most people in the industry now kind of understand this, given how large the government business simply is, and exchanges being government subsidized as well. I mean, I think people kind of understand that that's not possible to simply shift the cost, not least because what that would do is to accelerate further the movement that is happening. And so that is a clear challenge that exists in all of this, and that's where some of the innovation that we're talking about with different delivery models, et cetera, have to take root, because it's not like we can simply get there by paying our nurses less or, you know, doctors and so on. There has to be a material improvement in the kind of productivity, if you will, of the entire system, and that's becoming abundantly clear. I think, as Robert was saying, I think it's generally now well accepted that profitability at Medicare rates is something that we have to figure out. Roughly, if you do the math, that allows over a reasonable period of time to work the payer mix within that. So I do think that is going to be quite important to figure out, because there isn't more reimbursement to be had, whether it's the consumers or employers or anyone. It's not like, you know, in the classic economics test, people look at elasticity in healthcare. It's not anymore about elasticity, because the dollar spend is just so large, it just gets into affordability. I mean, actual affordability and being able to displace. What else would you displace from your spending?
One last question, very quickly. Right over there.
Yes.
You got it.
William Zogby from the Baker Heart Center and past president of the American College of Cardiology. Great discussion this morning. What I'd like to maybe ask your opinion on is, certainly we deal with a most complex care in the United States. And if we compare to anywhere else in the world from healthcare delivery, it is really the most complex and the most wasteful. Certainly there is an impetus for physicians and healthcare professionals to provide the appropriate care, but a big portion of that waste also is administrative care. And if you compare our healthcare compared to any other, at least 3 times administrative cost, much more costly than anywhere else in the world.
So what's the question?
So the question is, with the new exchanges and so many new players coming on board, is there a talk of some synchrony to improve efficiency of administrative care? A lot on the physicians, a lot of questions, and you know.
Sure. Ron, you want to take that?
Well, I think my perspective, excuse me, is that we've actually added administrative expense with the exchanges, and that what we need to do is to use information technology to kill all the paper and just really be able to automate the industry the way we've done other sectors as well. And I apologize, I'm on the tail end of the call.
All right, great. Well, we've run out of time, so thank you so much for joining us today. I thought it was an interesting discussion, and thank you for the questions. Appreciate it.